Alrighty. Welcome everyone to today's event. The Leukemia and Lymphoma Society of Canada is happy to present this webcast on advancing immunotherapy for blood cancers. Today, Dr. Natasha Kekre, hematologist at the Ottawa Hospital, will explore the latest advances in immunotherapy for blood cancers, including CAR T and bispecific. My name is Isabella Garofalo, and I'm one of the community services leads for the Ontario region, and I'll moderate this online event. We invite you to type your questions and comments in the Q&A box just at the bottom center of the Zoom window throughout the presentation, and an LLSC staff member will monitor the questions, and I'll ask some of them to the speaker at the end of the presentation. Due to the large number of participants and limited time, we may not be able to answer all the questions. Also note that Dr. Kekre cannot answer specific questions about a person's health history or status. And today's presentation will be recorded, therefore you can rewatch it again on our website. Next slide, please. Perfect. As we come together from across Canada, we recognize that we are on the lands cared for by many Indigenous nations. We honor the First Nations, Inuit, and Métis people who keep deep connections to these lands and enrich our community. We value Indigenous voices and are working to ensure they are truly represented in our leadership and staff. At the Leukemia and Lymphoma Society of Canada, our commitment to diversity, inclusion, belonging, and health equity guides how we work to support and uplift everyone affected by blood cancer. Next slide, please. Before we present our speaker today, I wanted to share the important mission of our organization. And are you looking for specific programs or resources but not sure where to find them? We're here to help. You can connect with the community services lead in your region to receive personalized assistance and get connected to resources in your area. You can reach out by calling toll-free at 1-833-224-884. Next slide, please. We invite you to visit our bloodcancers.ca website. Our goal is to better serve the community and offer an improved experience. That's also where you'll find your community services lead if you need to as well. Next slide, please. And on our website, you'll find tailored information and resources in multimedia formats to address the variety of needs and preferences of our community. This includes fact sheets, worksheets like the ones you see on your screen, and many more. Next slide, please. Thank you. We also have information and resources to listen and watch, like the series of animated videos on CAR T and on adapting to life after cancer and living with a chronic blood cancer. We also have a podcast channel called The Blood Cancer Experience. You can find hundreds of podcasts for people touched by blood cancer and caregivers, and many addressing challenges that people living with a blood cancer face. We speak to experts about current topics such as treatments, diagnosis, and research, and we will also hear personal stories from people touched by blood cancer. Visit bloodcancers.ca to read, listen, and watch all these great resources. Next slide. It is now time to introduce today's speaker, Dr. Natasha Kekre. Dr. Kekre is a hematologist in the Transplant and Cellular Therapy program at the Ottawa Hospital and a scientist at the Ottawa Hospital Research Institute. Over to you, Dr. Kekre.
Great, thank you. Can you just confirm for me you can hear me okay and looks okay?
Yes, we can hear you and it looks good.
So I've been tasked, I'm a hematologist at the Ottawa Hospital. I treat leukemia and lymphoma mostly, but mostly I focus on stem cell transplant and CAR T therapies. And so this talk will really be about where are we going with these immunotherapies? What do they look like? And how can we, how are we evolving over time? So I'll go over what CAR T and BiTE therapies are. That's really the focus of today's talk. I was going to focus on leukemia and lymphoma, but I will also include some data on myeloma, which is our other big bucket of blood cancers. I'll highlight some Canadian innovation in this space, and I'll sort of give my thoughts on what I think is going to happen in the future, what we're looking for. I always start with this story because I think it's really impactful. It tells us why immune therapies have become such a big part of what my career and what we're doing in blood cancers these days is like. So almost 15 years ago now, Emily Whitehead was a 5-year-old girl who had a bad form of leukemia, ALL, and started aggressive therapy with chemotherapy, as we normally would for ALL even now. And unfortunately, her ALL came back. She did not respond very well to chemotherapy. Within the year, she had relapsed. Her family, again, thought that the cancer had responded to the chemo, but it hadn't responded enough. So she wasn't able to get to a stem cell transplant. And so the family was told that really we had run out of options for her. And she was really, unfortunately, being palliated by her home team of physicians when her parents went looking for something in a desperate attempt to try to find something that could work for her in a clinical trial. In April 2012, they found a clinical trial online for this therapy that we're going to talk about today called CAR T cells. And Emily went on to get this therapy at the University of Pennsylvania. She was told that it came with lots of risks, but that she really, in her mind and her family's mind, had nothing to lose. It made her quite sick. No one knew if it would work. And she got incredibly ill. She ended up needing life support in the intensive care unit. Her parents, again, were told that there was maybe nothing that could be done and that she would possibly succumb to the disease or to this therapy. The doctors really did everything they could to try and help her, but she was not responding on life support. But things changed over time. While she was on life support, she started to get better. She started to not need the life support. Her blood pressure started to improve. Her lung function started to improve, and she got better. And eventually she went home and waited to see if the treatment had worked. And 1 month later, she got the news that her cancer was gone. And Emily is now a story that we tell over and over again because she's more than 10 years cancer-free. And what I most recently heard is she's planning to go to the University of Pennsylvania where she was treated with this therapy. And so she was one of the first children ever treated with CAR T therapy and really is what gave us so much promise and hope with this treatment. So why CAR T cells and where does this theory come from? Well, we know that the immune system reacts to our cancer cells, and it doesn't do a good enough job getting rid of the cancer, or we wouldn't have these cancers that grow in people's bodies. And so we know that there's ways that it can do that. The T cells, which are our immune cells, they are helpful in terms of fighting infections and bacteria and viruses and things like that. They often don't recognize the cancer as being a problem, those cancer cells. Second to that, the cancers can sometimes create barriers so that the immune cells can't get into them. And lastly, cancers actually have the ability to suppress our immune system. So they can actually hide from our immune system so that they can't be killed by our immune system. So that allows these cancers to grow and grow. So what could we do about that? Well, we can manipulate the immune system to potentially treat those cancers. And that's really where CAR T cells come from. So when people ask when was CAR T created or invented, I usually say in the 1980s by Zelig Eshar in Israel, who really found that if you could manipulate a T cell in a way that it could express something to directly attack a protein on the cancer cell, that potentially you could kill that cancer cell. And that was really when CAR T cell was born. People always ask why then in the 90s did we not see CAR T cells coming up? And it's because while this was the science behind it, there at that time wasn't enough for the cells to actually grow and proliferate in a patient. And down the road, later in life, in the early 2000s, we figured this out, and that if we added a domain into that T cell receptor to help to let the cells activate and grow, we could actually fight the cancer better. And so this is what a CAR is. So we use this word CAR, or chimeric antigen receptor. Chimeric means it has two parts to it that come from two different components of the immune system. One part is a tumor cell recognition, which really comes from what we know about antibodies, which are, again, a way that our body uses proteins to kill bacteria and things like that. And the second part of it is it allows us to activate the T cell with this co-stimulatory domain and the activation domain, which is the other part of it. And that comes from a T cell receptor, which we already know what that looks like. So if you put these two components together, you can build a CAR which has specificity for a protein on the tumor. So that recognition domain is really what we're talking about, can attack a specific protein, whichever domain we put on that CAR can attack a specific target in a tumor cell. And just so we're all on the same page about why this is so different and complex, this is a personalized therapy we're talking about from a patient's own cells. So first we hook up a patient to a machine called an apheresis machine, and we take out their T cells. We ship those T cells to a lab that can then re-engineer them and infect them with a virus that has the genetic material in it for that CAR, that chimeric antigen receptor. We then grow the cells to a level that we think is enough to give to a patient. And then we give a patient chemotherapy to sort of deplete their own T cells to make room for these CAR T cells. And that's the CAR T manufacturing process. How it's done and how long it takes completely depends on the product we're talking about, and the platform we're talking about. So it can vary from a few days to many weeks to months. It really depends on what the target is and what kind of platform we're working with. So the first success with CAR T cells was Emily Whitehead and kids like her in this paper for acute lymphoblastic leukemia, ALL. What they saw in that first paper was only 30 people were treated. That's not a large number of children and young adults who needed a CD19 CAR T. So the target here was CD19. 13 of those patients had neurologic effects. That wasn't expected. We saw hallucinations, confusion, seizures. And 22 of the patients had a flu-like illness called cytokine release syndrome, which I'll talk more about later, but can really look like a bad infection, fevers, high heart rate, low blood pressure, things like that, which that one we might have expected with an immune therapy, that it activated the immune system. But what was really remarkable was with only 30 patients treated, we were seeing responses in many of these children and young adults. We were seeing remission rates close to 90%. And I show this because the red curve is really what we would have expected the life expectancy to be for these patients who had been treated with lots of chemo and transplant and really didn't have other options at that time. Unfortunately, many of them would succumb to their disease. And so when we're talking about this newer therapy, to see a curve like that in a phase 1/2 design of a clinical trial is very remarkable. And truthfully, this is why the excitement in the field blew up at that time, because we saw that really, we were seeing success beyond what anyone could have expected. So that's what I wanted to start with for what CAR T therapies are before I get into where we are now. The next thing is BiTE therapy, which I'm going to get into as well. And this also banks on that technology that we can manipulate our own T cells against a cancer cell. And so what a BiTE is a bispecific T cell engager. So this is a molecule. It doesn't come from a patient's own cells. It's built in the lab just like any other pill would be, but it's usually in an IV or a sub-Q format. And really what happens is that T cell receptor is brought by this molecule into proximity of the cancer cell. It engages the T cell against the cancer, and it engages the cancer cell towards the T cell, linking the two together. And that BiTE molecule allows for the T cells to activate against the cancer cell. And so it's a different type of molecule. It's off the shelf, but it's another way that we can manipulate T cells to attack our cancer cells. And so before I get into what are the differences between them, I want to talk a little bit about the similarities. And the similarities really are those two toxicities. We're talking about CRS and neurotoxicity. So CRS, again, not really unexpected. You're trying to activate the immune system. So the side effect you're going to see is activation of the immune system. So cytokine release syndrome is basically that. It's releasing a bunch of cytokines, which are molecules that release when we're sick or when we're unwell from our immune system. And it can cause what we call an inflammatory syndrome, where patients can have, again, low blood pressure, high fevers, can even need support in the intensive care unit. And we have a treatment algorithm that's based on how bad the CRS is to treat this syndrome. The other toxicity, which we've seen with both CAR T and BiTEs, I don't think we expected when this field first started, was really these neurologic events where patients could forget where they are or could have headaches or confusion. There's still a lot of different theories about where this neurotoxicity comes from and what causes it and how could we better predict for it. There's still lots of work on that, but this is something we see with both BiTE therapies and CAR T therapies. So again, to make sure we're all on the same page before I start going into where we're going with this, let's compare them. So BiTEs, again, are probably a little bit easier to give. They're an IV infusion. It's usually a continuous infusion or monthly infusions. It is available immediately. It's off the shelf, right? We can get it from the companies or from any pharmacy that is able to do these inpatient treatments. They're usually done in some sort of inpatient setting. The cost is still high with BiTE therapies, but not as high as CAR T therapies, because CAR T requires the specialized, personalized manufacturing facilities, and that makes it even more expensive. The toxicity is the same between the two, but it is much more mild with the BiTE therapies, and that's important because it means maybe a little bit less monitoring, a little bit less frequency of going to the intensive care unit or needing to be on therapy for these toxicities. They're usually quite low grade. The bites don't persist. So you give that molecule and once it's used up, it's gone. So the bites require persistent, recurring, repeat dosing, whereas the CAR T therapy is a one-time infusion for the most part and is expected to last months to years. We think that Emily Whitehead probably still has CAR T cells in her body. And so access is a big difference, right? If you can have an off-the-shelf therapy, that's likely to be given it can be given in a community setting like the bites. CAR T therapy requires more of a specialized treatment center, and that would be a big part of the difference. So this whirlwind I just gave you in the last 20 minutes or 15 minutes was really to talk about what CAR T and BiTE therapies are. It's not telling us where we are now with myeloma, leukemia, lymphoma. That first story of Emily Whitehead, that was the initial excitement, but the field has already grown in the last decade so much that now I'll focus a little bit more on where are we right now in Canada for leukemia, lymphoma, and myeloma with these therapies. So let's start with leukemia. So I already showed you the data for a product that's now called Tisacel or Kymriah. That's the product that is approved in children with ALL and young adults up to the age of 25 for leukemia. But that's not really approved for adult leukemia. And so what we now have in the adult leukemia setting is Bruxacel or Tecartus, which was approved based on phase 2 data in a trial called the ZUMA-3 trial. What you're going to mostly see me talk about today is phase 2 data. That means data that tells us how these patients do on the new therapy. It's not comparing it. There's no randomized control trial. There's no big comparators. And it is unlikely to ever see comparisons in patients who don't have other options because we are not going to randomize patients to palliative care versus these new therapies. We can do it when we're talking about earlier lines of therapy where we can randomize patients to a standard of care option versus CAR T. But we can't do that for a lot of the current treatments that we have because we're mostly giving them at a stage in the disease when we can't offer other standard of care or we've already run out of standard of care options. So this was a study of 55 patients out of 71 who enrolled. 55 got to the CAR T therapy. And we always, in these earlier phase trials, try to focus on safety first. So I mentioned here that the higher grade CRS, or that cytokine release, that immune syndrome we talked about, and that neurotoxicity at a higher grade, which we now call ICANS, immune effector cell associated neurotoxicity syndrome. So I'm just going to call that ICANS. We now see that in about a quarter of our patients with this product, with this disease. And the median time of response on the trial was about 13 months. And now we have 3-year data for this. So we now know that this product, it plateaus. If you had a really good response, you're likely to stay in that response. When we look at this data now, they often stratify the data into responders, non-responders, because chances are if you responded, again, those curves plateau. So I think we're reassured by this, that the survival is quite good. Again, in a population of patients who didn't have great options before, we're seeing these curves plateau. We're seeing lots of lives are saved. And I think that's why this has become one of the standard of care options we now have in adult ALL. People will ask sometimes, what are the differences in the products out there? And this slide kind of shows that. So Tisacel is that product that Emily Whitehead got that I talked about at the beginning. Axicel is a product similar to the Bruxacel that I just showed. And Lysacel is a newer product on the market. And I'll talk about all of these in a second. But when we're talking about these different products, for someone like me, I often look at the different structures and the kinetics of it to see which patient populations are going to benefit. When we go to the market and we go and these are approved in the market, it's a little bit different because we often run with the product that we have access to that has reliable manufacturing, that the company works really well with our patients. It is different than a pill. And unfortunately, it has to be because we have to work very closely with these companies. Our hospitals write contracts with these companies. Again, something you don't do for a pill. And so it is more than just the structure of the CAR that's made that affects how we get these to the patients. But I wanted to show these products to show you that they are created different. Murine, or the word murine there at the top, means these were mouse-derived CAR T products, meaning that the target, that top domain, the binding domain, is derived from a mouse model. And those are relatively easy to manufacture compared to using a humanized domain on the top. And there's good and bad to both. When you have a mouse antibody there, you will have more of an immune system activation against it because it's from a mouse. But sometimes you want that immune activation in a patient to attack their cancer. So there's good and bad to each of these CARs in terms of the design. The co-stimulatory domain is also different, this CD28 versus 4-1BB. And that also matters for different kinetics in these CAR T. Some of them, the CD28 particularly, has a big expansion and then kind of more likely to go away. 4-1BB CARs are more likely to not expand as aggressively, but they last a lot longer. So there's, again, differences in the CARs. You can see here the starting material is a little bit different, that we use different viruses to get the genetic material into the CAR T. We expand the cells with different proteins and different molecules. And the dose is different depending on the CAR T product that's on the market. So they're not all created equal. So I try to remind people who are working in this field, or as we're progressing, that these differences, they do matter ultimately in terms of which CAR, is available to a patient and why. And so, like I said, we've talked about Bruxocell already. I'll talk about these ones now as we talk about lymphoma, because really, as far as we go right now, the Tisocell and the Bruxocell I already talked about is all we have in the leukemia space. So in terms of lymphoma, I didn't want to go through each product separately because they all have slight differences. There's lots of clinical trials out there, but I only have an hour, so I didn't want to bombard you with tons of data. But to say that with all of the products out there, the data is quite similar in terms of we do see the curves plateau when we talk about something called progression-free survival. We do see that over time, a proportion of patients will have a long-term response from the CAR T. They're all a little bit different in terms of their safety and toxicity. Some of them have higher toxicity rates, but maybe are a little bit more effective. And these are the things we have to think about when we're in the clinic making decisions. So I thought instead of showing you a whole bunch of different clinical trials, I would just show you our Ottawa data that I published recently that basically shows very similar results to the clinical trials. And you always have to wonder, when clinical trials are run in very controlled settings at very seasoned large cancer trial centers, like where I trained in Boston, for example, you have to wonder if you go to a smaller center like the Ottawa Hospital with maybe less experience in CAR T, will you see different outcomes? And we really haven't seen that. Our safety profile has looked very similar to what the companies have reported. And as you can see from this curve, our progression-free survival has looked pretty similar to what we've seen with the products. And 40% or more are having durable long-term responses to these CAR T therapies in lymphoma. And so all three of these products that I mentioned back here, all three of these products are approved in Canada. They're not all available currently, but they are all approved. And I'll talk a little bit more about access later on in the talk. So again, state of the art for leukemia, we've got 2 drugs. For lymphoma, again, CD19, we've got 3 CAR T products on the market in Canada. And now for myeloma, we have some CAR T products that are on the market. So this is a different target. So everything I've talked about until now has been CD19. This, on the other hand, is a BCMA target. And that means it's just a term for a protein that stands for B cell maturation antigen, which doesn't really matter. It's just a protein that sits on myeloma cells more than it sits on just lymphoma. This is a protein target that is found in plasma cells, the cells that really are implicated in the bone marrow and lymph nodes when it comes to multiple myeloma. There's 2 products in Canada, ide-cel and cilta-cel, which are both approved by Health Canada. And I'll talk again more about access to that in a moment. But that is, again, if we know the target on the cancer, we can make a CAR against it. So I wanted to highlight this Carvykti study with the cilta-cel because I think ide-cel was the first to market, but is an older product that we're unlikely to see coming to patients in Canada. Cilta-cel, we are expecting to come to patients. I liked this patient summary that was published with this study. So basically, this shows you that participants in this phase 2 study had failed 3 or more lines of anti-myeloma therapy. So that means they failed a Velcade-like therapy, a Revlimid-like therapy, a daratumumab-like therapy. And that means that these were patients, again, who had been heavily pretreated, did not have a ton of options out there at the time that this CAR T was available to them. And you can see the big breakdown of the types of patients that were treated on the trial. 84% of them had previously had 5 myeloma drugs. So again, these are patients who had had a good amount of treatment for their myeloma. I like this graphic. It kind of shows that there was high response rates in patients. So what we call a stringent CR, which is a very, very good complete response, I should say, like
post-stroke emergency.
Sorry about that. There's announcements going off at the hospital, as always. So these were patients who were heavily pretreated, and still we were seeing that really strict, what we call complete response. We were seeing that in a good proportion of the patients who were treated on this trial. And you can see in my next slide here, there we go. So I talked about the responses here. Again, these were patients who hadn't had previous responses. This was very exciting. But also we saw something new with this study, and that's why I highlighted this trial, is that we saw a different kind of toxicity. We started to see something that looks a lot like Parkinsonism, which means that they have features of Parkinson's disease without actually having Parkinson's disease. So movement disorders we were seeing in these patients with cognitive impairment, personality changes, which a neurologist, if they saw that in the clinic and didn't know anything about this therapy, might think that a patient has Parkinson's. And this is important because we are still learning a lot about these therapies as they come along, and we still don't always know why. So again, we've seen this with these BCMA targeted therapies. There's lots of theories about why this might be a side effect. It does, for the most part, respond to therapy or go away with time, but it is another side effect that is kind of newer in our treatments in terms of these CAR T therapies. So I just thought it was important to highlight that, because this is going to change again for people like me. When we treat myeloma for CAR T, we're going to have to think about these newer toxicities. So as promised, I'm going to talk a little bit about the current state of the art with CAR T and where we're going for access. So I said that there is axi-cel, Tisacel, and liso-cel, these three right here, which are approved in Canada for different types of lymphoma. Bruxa-cel is also approved for adult acute leukemia and mantle cell lymphoma, which I didn't show that data today, but it's very similar in terms of seeing responses in patients who fail therapies. And then we have ide-cel and cilta-cel, 2 therapies approved by Health Canada for multiple myeloma. But the real question is, which ones do I have access for patients today in Canada? And the answer is only 3 of them. Axi-cel, Tisacel, and Bruxa-cel are the only therapies that my hospital currently has access to for these patients, and that is a problem in my mind. These are therapies that are now, approved and available for years, and we still available as in approved by Health Canada, but we still don't have access to them. And I'll talk a little bit about the reasons behind that. But there's many, and there's still we're still at just these 3 therapies for now. More are coming. We're told that liso-cel any day now we should be able to give to our patients, but it is a slow process. So I'll get back to this issue of access to CAR T when I talk about access in general and Canadian innovation towards the end, but I'm going to switch gears now and explain a little bit of the current state of art for BiTE therapies in these same diseases. So I'll just again remind you what these BiTEs are, and this was the first BiTE to the market for us, blinatumomab. This is a CD19 CD3 T-cell engager. So the CD3 is the target on the T cells that it engages, and CD19 is the target on the tumor cells that it engages. And this molecule, blinatumomab, brings them together, helps the T cell to activate and kill that tumor cell. And that's really what the BiTEs are all about. So blinatumomab has quite a bit of data now. It's been around for a while, but I highlight this study because it's probably the most recent data we've seen for Canadian patients, or affecting Canadian patients. This is 224 patients with B-cell ALL, and it has to be B-cell because CD19 is located on B-cell ALL, not T-cell ALL. And these were patients who actually responded really well to induction chemotherapy. But the theory, again, is that many of these patients are still, they can relapse. And so why not improve upon their therapy right at consolidation, or that point in time when they've responded to that initial chemo? So this was a randomized study. And remember, I said it can be randomized if we are comparing it to a standard of care option, which is what we call consolidative chemo, which is chemo we give you to keep the disease at bay. So blinatumomab plus chemo was one arm of the study. Consolidation chemo was our standard of care in the other arm of the study. And this is for adult patients. And here's what the results showed. With blinatumomab and chemo, the survival was better, the relapse-free survival was better, the outcomes were better. Now, not surprisingly, there was more adverse events because we are adding more therapy, not less, right? And so we do expect there to be more adverse events. So there was high-grade neurologic and psychiatric adverse events in the blinatumomab group, 23% versus 5% in the chemo group. That was significant. But despite that, survival was better, and relapse-free survival, meaning time without any therapy or any relapse or progression of leukemia, was better with the blinatumomab arm. And that's where this therapy is now going. We're seeing blinatumomab being used much earlier in the disease course for ALL because of these newer studies that are comparing it to standard of cares that we use in the earlier settings. But when blinatumomab first came on the market, it was for those very relapsed refractory type patients who had failed standard therapies. It's good for the field and it's good for these diseases to see it moving up in the chain for patients to get benefit from it early on and not have to wait till they have failed a whole bunch of chemotherapy. So where are we at with BiTEs and lymphoma? So this is a much newer story. So we've got 2 BiTEs available for lymphoma. Epcoritamab is the first one I'll mention. It's a CD20, so again, a target on the B cells that are in lymphoma. That CD20 is on the cancer cells. CD3 is on the T cells, and just like that last picture I showed you, these molecules bring together that tumor B cell and the T cells and helps the patient's T cells kill that tumor cell. This is, again, approved in patients with relapsed refractory disease. So these are patients who have failed standard chemos, and that's because this is just coming to the market now. And the EPCOR study, which is how this product came to the market, showed that in these relapsed refractory diffuse large B-cell lymphoma patients, the overall response rate was 61%. And again, this is when we're talking about patients who didn't have therapy options really and were failing standard of care chemotherapies, maybe a transplant. And so this is very reassuring to us that we're seeing good responses in patients who really weren't responding before this. Glofitamab, I'll talk a little bit about the differences between these products. It's the same idea, CD20, CD3, BiTE. But the responses looked quite similar. It's a bit different in how it's infused. The first studies for this product was a fixed duration treatment course that included an antibody therapy called obinutuzumab. And so the design was a little bit different. You can ask me why. I can't tell you for sure why this one was with a therapy, another therapy, and the other one wasn't. It's a different design by different physicians, different companies. So in terms of the differences, I tried to pull this together. You know, there's a few different lymphomas that are treated by one versus the other. In both situations, you have to have failed 2 lines of chemotherapy or more. One is subcutaneous, one is an intravenous infusion. They both have a dose ramp-up stage, which allows them to, start low, look for toxicities before you get to full dose. Both of them have a decent incidence of CRS, that's that cytokine release we talk about. But these are, for the most part, low grade. We're not talking about high grade for the most part. But they do require that first time you get full dose, some kind of monitoring or even hospitalization. And so while this might seem easier to give to patients, it still does require intensive resources in the hospital to ensure that we're monitoring them properly. And luckily, neurotoxicity has been very low, but because that remains our concern, that is the one that drives how we make decisions of capacity and how to do these in the hospital, because even though it's only 6 and 8%, that still means 1 in 10 patients is going to maybe have some neurotoxicity, and that's something we have to really be ready to handle in the hospital in terms of management or hospital admission, things like that. So those are the 2 lymphoma BiTEs that we have, and there's many more for myeloma. So I first, when I made these slides, was going to have a slide on each one and talk about the data, but it gets a bit exhausting to go through all of them. And we only have 1 approved and available in Canada. There's others approved, but again, not available to Canadians. So I didn't want to harp on that. But teclistamab is the BCMA CD3 BiTE that's available in Canada for patients who have failed 4 lines of therapy. And for those who don't know, myeloma, that would be expected because patients can respond quite well to 2nd and 3rd lines of therapy with myeloma. So this is a patient population that has failed basically all the options we have available to them. before they would go to this BiTE therapy. Again, it works quite well. Toxicities are quite similar to what we've seen with the lymphoma BiTEs in terms of low-grade neurotoxicity, low-grade cytokine release. Again, we've seen some interesting things. We've seen skin rashes and peeling of the skin with one of these BiTEs. Again, the Parkinsonism has not been as much of an issue with the BiTEs, but is something that people are watching for. But again, we're talking about much smaller numbers than what we see with the CAR T therapies. But there's lots of BiTEs coming for BCMA and now this GPRC5D, which is another target of plasma cells and myeloma cells that we can target with BiTEs and even with CAR T. I didn't mention that to date because there isn't any GPRC5D CAR T on the market, but that's probably coming too. So in my whirlwind of BiTE therapies, the current state of the art is they're now available in Canada for all three of these, leukemia, lymphoma, and myeloma. But really, in having more options for these patients, we have more questions. And really the question is, how do we sequence these therapies, especially with CAR T? Most of the patients who got BiTEs have failed CAR T therapies, not because they should have failed CAR T to get to BiTEs, but because the history of it is that CAR Ts were on the market first. And so the question is, should they be before a BiTE? Should the CAR T be after the BiTE? We don't know. While it might seem easier to give a BiTE therapy, there's questions about durability. Do they last as long? Do they work as much? You know, Emily Whitehead was treated over a decade ago, but most patients treated with a BiTE have only been treated in the last maybe few years. So we don't have that same level of long-term data to see if the curves are going to plateau. And so we have to watch for that. So I'm often told, well, let's use a BiTE. It's so much easier to give. But there is still some infrastructure and training and specialized care that's needed for BiTE therapies. And we just don't know how that's going to look if you replace current standard of care like CAR T with the BiTEs, what that's going to look like. In my practice, and mostly in Canada right now, we're still reserving BiTE therapies after CAR T therapy because we have decent data at this point that the CAR T is durable and maybe the BiTEs might not be. So we don't yet feel comfortable enough to give a BiTE up front to everybody. And I think we're going to see a lot more data on this, hopefully even some randomized data to help us decide what to do next for these patients. So that's really all I wanted to say about standard of care. And now I want to focus on what's coming. What's the future going to look like? What do I expect? I'll talk about a few products, but more concepts, because that's what we're going to see. And so the first concept I'll talk about in the CAR T space is less toxicity. You know, I've talked about CRS, I've talked about neurotoxicity, I've talked about the fact that, you know, patients can go to the intensive care unit. What about newer therapies? Well, maybe they can be less toxic. So obe-cel was just approved by the FDA. This is a CD19 CAR T therapy, so very much like the Tisacel and the Bruxa-cel in leukemia. But it's a different interaction. The binding of that domain, the binding domain, has a reduced affinity for the CD19, which means it doesn't interact with the tumor cell as long. And potentially, if it has a fast off rate, then maybe that means it can be a bit less toxic. So if you see on the right picture there, controlled binding with a fast off rate, controlled level of cytokines coming out, maybe you're going to have less toxicity. And maybe the other theory is because you're having less T cell exhaustion, they're not being activated the whole time. Maybe you're going to have less trouble with T cells exhausting or not working in the CAR T space, and you'll have persistence or enhanced effect of the CAR T therapy. And so that's what obe-cel is. We don't know if the company has any intention of filing in Canada, but we hope so. But this is a therapy that I think is going to be, you know, what we've seen in the data, the FELIX study has shown lower toxicities than the current available therapies in ALL. The next thing we're going to see in the next generation of CAR T, I think, is off the shelf. So it is difficult to take a patient's T cells. You need time in an apheresis bed to get their cells collected. Then the patient has to wait, sometimes many weeks, for the product to come back. Patients don't always have many weeks to wait, then they get it back. What if we could just give a CAR T cell that's sitting on the shelf somewhere and just infuse it into a patient? So the idea behind this is that you could use maybe use a different cell source than T cells, something like NK cells, which are natural killer cells, another type of immune cell in the body. And maybe if you use those cells, they don't have that same recognition site that T cells do. They can be given from a third-party source, and we can source them from a cell line that's been created or umbilical cord blood. to generate a bunch of CAR NK cells that can be given to multiple patients off the shelf and ordered from a company, for example. There's other ways to give CAR T that are not directly from a patient. You can give donor-derived CAR T cells. Again, this could create accessibility. If you take one donor and make a whole bunch of CAR T type products that you could give to a population of patients, maybe that would be another off-the-shelf solution. So there's lots of different ways that people are looking to create off-the-shelf solutions. So we talked about something less toxic, but here it's something that's easier potentially to give if we don't have to worry about collecting cells and waiting for a product to be made. And then, of course, the one that everyone wants to see is better CARs, so better CAR T therapies on the market. This will look like, I think, CAR Ts that have a target, multiple targets that they can hit instead of just one. So, you know, instead of targeting CD19 in ALL, could you target CD19 and 22? We're seeing those trials now. Could you arm the CAR? So could you give something with the CAR T product that activates the immune system even more so that the CAR T is more effective? And the most recent data we saw at ASCO this past year was from UPenn again by Carl June's group out there to look at a humanized CD19 CAR with IL-18, which is actually a cytokine that maybe can help with the effect of the CAR. And so we saw good efficacy data in a phase 1 design for relapse refractory non-Hodgkin's lymphomas. And that's really this 4th generation armored CAR that I'm talking about on the right there. Those might be the way that we can change how effective the CAR is with time. Now, those are just a few examples. There's so many more. People are looking at ways to turn on and turn off the CAR, meaning we could give you the CAR and then we give you a pill that turns on the CAR, then we give you a different pill to turn off the CAR, or we generate a CAR based on your specific tumor. We look at the proteins in your tumor and make a dual or triple target CAR that has all just those specific targets on them so that they're specific to the type of cancer and the type of disease you have. There's so many ways that this is going to evolve over time. And I think that it's a great time to be in this space for me as a clinician and a researcher to see how fast the field is evolving with new ideas and how to really work with this technology. So I want to get back now and change gears completely and talk about my Canadian program called CLIC, the Canadian-led Immunotherapies in Cancer. Again, you can tell from my frustration, I wish we had access to all of these brand new CARs that are coming to market or even in clinical trials, and we unfortunately just don't have that right now. And so myself, along with a lot of physicians and scientists across Canada, recognized this as a problem back in 2017, and we worked to develop a Canadian solution. So we built this CLIC program with a vision to develop a Canadian model for cell therapy research and delivery to build expertise and infrastructure, create jobs, and foster innovation, and really allow Canadian science for Canadians by Canadians to reach our Canadian patients. And our strategy was that we would make the genetic material and the virus in one place. So we already had the ability to make plasmids in the genetic material itself with Dr. Rob Holt in Vancouver. We could make the lentivirus with Dr. John Bell here in Ottawa. And then we could do what we call point of care or decentralized T-cell manufacturing. So we could plop machines in different centers to make the T-cells. We started that with Dr. Brad Nelson in Victoria, BC. And that's how we built the program. We started with the CD19 CAR because we knew that that was where the clinical need was when I came back from my fellowship but just before 2017. We knew that we needed something that would be a benchmark. People would believe that if it worked like the other products on the market, that we had a benchmark to hit. So we started with our own CAR, CD19 CAR, as a proof of concept. And back then in 2017, we had no access to CAR T in the market here in Canada. Well, that CLIC network has grown significantly. We have clinical partners now across the country. We now have our first 3 pediatric centers who are opening one of our clinical trials for pediatric ALL. We still have manufacturing of the T-cell product in Victoria under Dr. Nelson, but we now have T-cell manufacturing that we're building both in Ottawa and Winnipeg and other centers across the country. Slowly but surely, we're getting there. We still have centralized manufacturing for the virus and the plasmids, but really this has been a journey from a very small group of people who were like-minded in what they wanted to build to now we've treated over 90 patients on our first trial. We've treated a handful of patients on our second trial, and we continue to grow across Canada. And so that decentralized manufacturing for the T cells, we think that, one, that's a Canadian solution. It lowers costs. It works within labs that we have already across the country. We're not building new buildings to do this. We are a fresh out, fresh in product. So we take out the T cells. In Ottawa, if I have a patient, they get shipped to Victoria. Within 12 days, they get shipped back to Ottawa and they go in fresh to a patient within 2 weeks of taking them out. That's incredibly fast. By building these hubs all over the country, we're trying to standardize protocols. So we're all following the same manufacturing platform, which really would allow us to keep going with these made in Canada clinical trials that we're trying to build. And we're doing all of that under a not-for-profit called BioCanRX. We've had lots of funding and support from Leukemia Lymphoma Society of Canada as well. But BioCanRX is our Canadian immunotherapy network that really funded this, what we call the enabling, bridging that, amazing science from the lab to the clinic. They were the funder that could fund that bridge when no one else was funding that bridge for us. And so in 2017, this was all generated through the help of BioCanRX to build this network across Canada. And really, I'm so proud to say that now we've built quite a bit of it. We now have a pipeline for plasmids, for virus, for patient partners, clinical trial protocols. We have new trials coming on the market for rare sarcoma, triple negative breast cancer, acute ALL, like I said. And we're also helping other countries who believe in this vision of bringing academic-made CAR-T products to trials. So Denmark, for example, has a partnership with us. They have used everything from our CD19 trial and opened a trial very similar in Denmark with our help. And they've now treated quite a few patients and are seeing similar results to us. So we're very happy with that partnership as well. And we're starting to partner with other countries who really believe in this vision of building domestic manufacturing and academic CAR-T programs. So that was really a whirlwind of where we're at with immunotherapies. I can't say what's coming next for BITES because they're so new, and I think that's going to change with a lot of time. And I don't know yet where that's going, but it's amazing how much this field has changed in my career. I think a lot of the innovation in this space is to find solutions to safety and durability. But in Canada, I think the innovation is really in how are we going to find better access. In the US, where they have access to lots of marketed products, still we think about 20 to 30% of patients are getting access to CAR-T therapies when they need them. And so in Canada, I don't know what that denominator looks like, but I can't imagine we are doing that differently with less products on the market. And so I think we need to keep building domestic manufacturing, domestic development. And so then if a Canadian scientist has a great idea for a CAR-T therapy to get to clinic, now they have a pipeline of how they can maybe do that. And that's what we're trying to build in Canada through all of the partnerships and funders that we have. Normally, I show a big slide of all the people to thank, but really it's funders and patients that we thank the most, patients for putting their faith in us to run these trials, to be treated on these trials, and then our funders like BioCanRX, LLSC, CIHR, and others who have really put money behind running these clinical trials so that people like me can build this network and this platform so that more trials can come in the future. So that's where we are today. I'm very hopeful for the future in this space in Canada and elsewhere, and I will happily take questions. I think I have to hand it back to LLSC to end with a few more slides.
Yes, thank you. This was incredible information. So thank you to Dr. Kekre for sharing your expertise and insight with all of us. I will now invite the participants to ask their questions of the Q&A box, and I'll ask them to Dr. Kekre. Due to the large number of participants and limited time, like I mentioned, we may not be able to answer all of the questions. And we also want to make a note that Dr. Kekre cannot answer specific questions about a person's health or history status. So to kick us off, one of the questions that we have sitting in the Q&A box, for patients that are CD19 VE, what success is being seen with CD22 CAR-T or other CAR-T trials?
So the question is, what about CD22 with patients who are CD19 negative? It depends on the CD22 CAR we're talking about. So in Canada, we built a CD22 CAR it's a llama-derived CAR, so it's made in llamas, which means it's more immunogenic than a human, less immunogenic than a mouse. It's somewhere in between. So we're hoping that leads to good outcomes, but it's too early. We just started the trial. We've only treated a handful of patients. I can't comment on results yet. There is a CD22 CAR out of the NIH in the US that has had success. CD22 is a viable target, I think, in patients who have CD19 negative disease or relapse after standard of care therapies. But I would say it's too early for me to comment on what the overall outcomes will be with that, because we haven't seen longer term, larger patient data sets to see what that looks like. I just also wanted to make sure that we highlighted the partnerships and support here. So I'm just showing these slides, and then I was going to stop sharing so I can see faces in the questions.
Yeah, perfect. Thank you for answering that one. I can jump and highlight those pieces there. So this event is in partnership with BioCanRX, as Natasha Kekre spoke about. And this presentation was made possible thanks to the support of Bristol Myers Squibb and Johnson & Johnson. And then as well, we are here to help. You can contact us at info@bloodcancers.ca or toll free at 1-833-222-4884. And at the end of the question period, we can bring that slide back up as well. So I can jump to the next question there. Is there a direct correlation between the level or strength of expression of CD19 and a CD19 CAR T effectiveness? And is there a minimum level of expression needed for success?
Yeah, it's a great question. We don't think that they directly correlate. I think in ALL, we have more data because it's easy in ALL to take a biopsy and look at CD19 expression. In lymphoma, we don't even look for it anymore at this stage to really treat a patient. So we expect that it works. There's some theories that the level of expression doesn't matter, but there's others who think the density of the CD19 could affect the efficacy. I think the verdict on that is still unknown. And for sure in myeloma with BCMA, I don't think we have enough data to support one way or the other.
Thank you. I'm going to fly through some of these other questions. I'm trying to loop them into which ones are related, but let's say, is there any research or trials using CRISPR-Cas9 for blood cancers like CLL in Canada, and any timelines?
No, there's none that I know of in Canada currently, and none that are planned just yet. I think that's a great plan to have a CRISPR-Cas9 CAR would allow us to genetically modify the CAR in some way. We do, the CLIC trial is open for CLL, but we do not have a specific CLL CAR in Canada that I know of at this point. But there are definitely some in Europe and the US.
Thank you. Another person wanted to know, aren't the off-shelf CAR T therapies going to be less efficacious? You know what I'm trying to say. And what needs to happen beyond domestic manufacturing to further make CAR T therapy more affordable and accessible?
What was the first part of the question? The second part's much bigger.
Yeah, it was, aren't the off-shelf CAR T therapies going to be less effective?
I don't know. It depends on it. We talk about these things in buckets because it's easier for me to present that way, but it really depends on the therapy. I do think CAR NK, there's been some great data on this, and yet it has not come to market. It has not been picked up in any real way. It's not commercialized yet for patients. So why? I always ask that question. Why is it still not there for patients? And so I wonder if it has a lot to do with the way those cells are made, the cell source, where we source the cells from and how we make them is maybe not consistent across batches, hard to know. So I think it will really depend on how what the off-the-shelf therapy is and what they're knocking out or what they're doing to the cells to make them so that they can be given to a large group of patients. And I think something will win in that market. We just don't know it yet. What else can we do for Canadian access? It's a great question. I think we need to keep advocating for more than just a little bit of clinical trial funding. As you've maybe seen in the news recently, a lot of Canadian innovation does not stay in Canada because we don't have a pipeline here to market it, to commercialize it, to get it across the board, to get it across the finish line. And so I think Canada needs to invest in that side of it if they want programs, even like mine, to be sustainable. So while I've had great success in building clinical trials, I have not yet had great success in how I'm going to bring that to the market outside of the trials. And I think that is a tricky place, a gap right now in the Canadian funding landscape. And I think beyond that, our issues with commercial CAR T right now is that we've created a system where we've made it redundant and logistically challenging, where each hospital is making a different contract with each company, despite the same concerns regarding sharing of data, privacy, all the things that go into contracting. Why in Canada we couldn't do that differently so that we streamline it and make it easier for our hospitals or our provinces even to make this available to our patients. This is all work I do all the time. I'm constantly advocating to make it better. I really do think that we could do so much more, and there's a lot of little things that I think if we could advocate for fixing in the system, we could bring more access, but it will take time. These are still new therapies with very complex manufacturing.
Thank you for that. There was a couple questions around the advocacy piece, so thank you for touching on that one there too as well. We also had someone ask, so is Emily Whitehead more of an exception, or are there more cases where long-term remission has been achieved by CAR T therapy?
We have lots of cases like Emily. We always talk about Emily because she's the one in the news the most. It's easy to show her face and her story. In my own practice in CLIC, I could have shown patients like Camille Leahy and Owen Snyder, who have also been in the news. These are patients who were also cured many years out from the CLIC trial, doing very well. Camille is a great example. This is a young woman who had very terrible ALL, who has, very publicly said that, she wouldn't be here if it wasn't for CAR T therapy or the CLIC trial. And she's now 3 years or more out in complete remission. So we have, I can name you lots of stories like that, both with commercial CARs and with our CLIC products. I think we are curing people and having long-term durable responses. And I think that's what makes me excited about this field. It's not as high a number as I'd like at this point. It's probably still in the 40 to 50% range, but it's there.
Thank you. In a little bit of a different vein, would any of these therapies be suitable for MDS patients who do not respond to azacitidine and or have germline mutations?
Yeah. So on the myeloid side, so things like AML, MDS, CMML, all these different myeloid diseases, we don't yet have a target that has really been shown to have a CAR T that works. So unfortunately, not yet, but everyone's working on it. There's lots of great early mouse data that suggests that there's different targets we could use in these myeloid diseases. And I think we'll see that with time. We just don't have it right now.
Thank you. And then we also have a question. Does absence of CRS post CAR T in some way indicate that the CAR T is not working as well, or does it depend more on the patient tumor burden?
Yeah, so now we do have some evidence that a patient's disease status or the burden of disease going in is implicated in how much toxicity they might have. But whether that toxicity means the CAR is there or not, I don't worry as much about. So I used to worry if they weren't having a fever, there was no CAR T activation happening. But really, it's all dependent on so many things: the dose, the patient's, how sick they are going in, how much disease they have, how inflamed they are, all these different factors. And so, no, I don't think anymore that we believe you have to have CRS to have a response to the CAR or even the bite. You don't have to have a fever to show a response. It's a great question, but I think that thinking is changing quite a bit.
And then kind of related as well, someone wanted to know, are there any biomarkers or patient characteristics you would focus on to predict which patients will respond better to CAR T or bites?
So this is why we need programs like mine and all of the academics who are working in this space, because a lot of that data about predicting outcome is held by the companies that acquire the patents to have these products. So while there's probably amazing data to compare CAR T and bites and tell us which patients would respond to which, that data is not in the public domain and not compared, because I don't think we're going to get the companies together at the table to show us that data together. So that's partially why academics maybe will answer that question, but it's going to take a long time. And now, as we build real world data sets, we'll be able to look into that. We don't have enough data for that just yet, but it'll come.
Thank you. And then it looks like, from what I could see, the last question we have here is, with the short duration of activity with bite, is there a chance that target cancer cells would evolve immunity?
It's not so much that they evolve immunity, but target cells can change so that they can downregulate that tumor expressor, right? So if it's CD19, the bite, you can downregulate the CD19 to have a CD19 negative progression or relapse. You can have that the bites, are working on exhausted T cells over time, so the T cells no longer are effective against the cancer. There is lots of different mechanisms for why bites and CAR T stop working, and some of them are related to the tumor, some of them are related to the immune system, and some of them are related to the product itself and the kinetics of it. So it's a hard one size fits all for the answer, but really there is differences in all of them.
Wonderful. Thank you. I think that is our last question that we are able to answer or ask today, sorry. And just a reminder to folks, we couldn't get to all of them, but if you have additional questions, please feel free to reach out to LLSC and we can work to find the answers for you. Thank you again to Dr. Natasha Kekre for sharing your expertise and insight with all of us. We really appreciate it. And then one last time, just wanted to share a reminder that we're here to help. You can contact us at info@bloodcancers.ca or toll free at that number 1-833-222-4884. Please note that a short survey will be sent to all participants after this presentation. Thank you for being with us today and take good care of yourself, everyone. Thank you.
Thanks, everyone.